Welcome to the Center for Digital Transformation of Health seminar series. Yes, thank you. And we do know it's school holidays, and so a lot of people might watch this on video afterwards, but thank you for those of you that were able to come today. Very happy to have with us today Professor Anna Peeters. And Anna is Professor of Epidemiology and Equity in Public Health and Director of the Institute for Health Transformation at Deakin University. She's a public health researcher that's interested in the provision of information to facilitate objective and equitable choices in public health and health policy by policymakers, practitioners, and the public. Anna and I collaborate on a project that's funded by the Victorian government called the Victorian Collaborative Healthcare Recovery Initiative, and it's been such a pleasure working with her, so I'm really happy to introduce her to you all and hear about the great work that she's doing. So welcome, Anna.
Thanks very much, Wendy. And I just have to apologise to everybody that I apparently am looking very dark because with school holidays, the children have taken over the house. So I'm trying to put the light on me, but just yell out if I really fade into nothing. I'm going to share my screen and just double check again that that's the right page you're seeing.
Yep, that looks great.
Super. Look, thanks, Wendy, for the invitation. It's a real pleasure, as you said, also to work with you and to meet some of your team and probably the wider group. So I wanted to talk today about what might health transformation mean from a research perspective and why do we need it to address current complex health challenges. I want to start with an acknowledgement of country. You know, we're all physically dispersed at the moment. Our land and space and interactions are virtually constructed. So I think it's really nice to take a moment to reflect on the meaning of place and think about the various traditional lands on which we're doing our business today. And I'd like to acknowledge elders, past, present and emerging of all the lands that we're working and living on, and also to pay my respects to other Aboriginal and Torres Strait Islanders present today. So the outline for today's talk is really to talk through what I see as some of the current challenges for the health sector, why I think that means that we really need to embrace health transformation, and then to talk a bit about what I think the role of research is in that with some case studies from across the Institute. So just a little bit about me, as Wendy said, I'm really focused on what's the role of evidence in informing objective and equitable public health policy. And because of that, I work with a range of partners, government, non-government, health sector and independent to deliver policy and practice, and funded by a range of different funders who I'll also acknowledge at the end. So what do I see as some of the current challenges for the health sector? So this hopefully won't be new to you, but I think it's sometimes useful to bring it all together. So I think some of the really overriding characteristics that we can pull out include the fact that a number of the challenges that we're facing are systemic challenges. So they're not kind of small, isolated problems that we can solve with a small, isolated research project. How we address systemic challenges, I think we're still grappling with, and I think it's something that requires a lot of attention and thought, and I'll come back to that later. One of the things that's emerging as increasingly apparent around the world is the increasing lack of integration of health systems, services and systems, research and development. And I've kind of deliberately put it there as R&D, because I think what we're getting to starting to recognise is that while a lot of other industries have integrated research and development, whether you think of manufacturing or agriculture, in fact, health doesn't. And there have been times in our history where we've had a much better integration of research and development within health services and systems. And I think, and I'll make a case, that I think we need to go back to a much more integrated approach to health research to get the best outcomes for health services and systems. And I want to talk a little bit now about the idea of a VUCA environment. So the current environment for health and lots of other things, obviously, is a very volatile, uncertain, complex environment. And I want to just touch on that for a moment. So what is VUCA? It's really talking about environments that are high in volatility, uncertainty, complexity and ambiguity. And just to put a bit more meat on that, I quite like this schematic. So complexity is talking about an environment in which there are multiple key factors that are related to the decisions that have to be made. And those are not just, there's not just a lot of them, but they are connected to each other in multiple different ways. So it's not just complicated, it's actually a complex system. Volatility, obviously, as the word suggests, is talking about the rate of change in a system. And I think if you think about health at the moment, it's really obvious that it's a complex system, that there's a lot of volatility in the system. Then things like ambiguity and uncertainty, they're interrelated. And what they are really talking about is that we can't actually predict with a high degree of certainty what the impact of a particular change will be. So with the best will in the world, we might want to improve the systems, but we don't have a clear roadmap, to use a word of the moment, in terms of, well, if we do A, we know B will happen. So there's both a lack of clarity about what the impact of a particular event might be, and also a high degree of uncertainty across the health system, whether we think about aged care, mental health, or health services, about what actually might happen next, given the multiple factors pressing down on health at the moment. So I think I find this sort of VUCA, if you like, a really, really useful way of thinking about why we actually have so much trouble making the large impacts in a positive direction across health, even though so many people are pulling in the same direction. And so if we reflect on our health context at the moment, and I've put current in brackets here because I think, you know, what everybody will have thought of immediately when we talk about VUCA is COVID. I mean, COVID is so obviously driving a VUCA kind of response and environment, but actually health more generally, more broadly, and in a really sustained way, has all the hallmarks of a VUCA system. So if we think about the fact, as I said before, if you think of all the royal commissions at the moment into disability, aged care, mental health, we're talking about system reform. So none of those are simple. There's not going to be a simple solution to any of those challenges. When you think about new models of care, again, this is not a simple A to B equation. And I know a lot of you work in the area of virtual care, and obviously virtual care itself has a lot of the hallmarks of a VUCA environment. And I'm going to go into that in a little bit more detail. And that the point that I really want to make is, you know, integrating virtual care properly into health systems is not just a technical question. And so I think it's very useful to think about, well, what are the aspects of the environment that we call health that make it a much more complex issue to actually get traction on. And so what I find quite useful in this context is the work that Ronald Heifetz has done in terms of adaptive challenges and adaptive responses. And so if we think about how we might need to respond to these complex systemic challenges, one way of thinking about it, obviously it's not the only way, but as I said, I think this is a really useful toolkit, is to think about the fact that they're actually adaptive challenges which require adaptive responses. And so what does that mean? So if we think about the way that Heifetz talks about it, is there are technical challenges or there are adaptive challenges. So technical challenges are probably the ones that, you know, we are quite familiar with. They're fairly easy to identify. They usually have a quick, well-known solution. They require quite small changes, and you know which changes, and you know that if you make those changes, you're fairly confident of the outcomes. And to find out which changes to make, then you know where to go, that you go to a particular expert or a particular authority on that technical issue, and you find the solution for your problem. It's a bit like calling, you know, the IT help desk. Generally, you have a problem and they are the expert and they can tell you which steps to take, and that fixes your problem. In contrast, an adaptive challenge, it can actually be quite difficult to even identify what's the challenge. Like, we know something's not working, but we can't really get a handle on which bit of this do we need to focus on to try and get an improvement, because, as we said before, it's a complex environment with lots of moving parts. And if we're going to deal with an adaptive challenge, then often what we need is not just this technical expertise, but really shifts in values, beliefs, and the ways of working, or how we work. And that's a really different way of thinking. And so it requires a lot of change across many, sometimes unknown at the beginning, different boundaries. And one of the kind of responses to an adaptive challenge, which I think from what I know of your centre will resonate with you, is that it requires experimentation and involvement of those who experience the challenge. So you don't just have to you can't just go to an expert, you actually need to engage those who are experiencing the challenge, which in health, obviously, it could be the patient or the consumer, it could be the healthcare practitioner, and it could be the support staff. So just to kind of make that super clear, and I'm sure many of you have heard of this already, but if we think about, for example, a technical versus adaptive challenge, if you're thinking about, delivering virtual care, so let's imagine some kind of tele appointment, then if the patient loses Wi-Fi, that's a really technical issue or a technical challenge, and they need to reinstate the Wi-Fi, and then the problem is solved. But if you're talking about something like rolling out a whole new virtual care initiative, then it's clear immediately that's an adaptive challenge, which requires attention to lots of different moving parts. Similarly, if you think about home visits in healthcare, working out the quickest route to a home visit, that's something we might get our electronic map up. It's a technical question with a technical solution, quite rapid, quite well known, so long as you've got the tools. But if you think about the other components of home visits, so integrating all the relevant social and healthcare items for a home visit, then clearly that's much more of an adaptive challenge. So I'm happy, I can't see the screen, so if people have any questions, then please put them in the chat and Wendy will shout out and let me know, or feel free to shout out. So I'm just going to pause for 2 seconds in case somebody wants something clarified before I keep going. Great. All right. So I think just to sort of really underscore why I think it's so critical that we have a very good understanding on what are technical challenges and what are adaptive challenges and responses, and why we need both, and how we make sure that we're applying the right responses to the right problems. I think it's quite useful to reflect on our COVID-19 vaccine rollout. It's not a political talk. I'm not going to go into politics at all, but I think it's about human behaviour and human nature and our capacity to deal with adaptive challenges. And so I think if we think about our rollout, I think where we've been really good in Australia has been the technical challenges. We've been really, really clear on articulating the numbers of vaccines that are available, the processes that they need to go through for approval, the delivery dates, the delivery pathways have all been clearly articulated. Risk estimates have been clearly articulated. So there's been a lot of focus on, these are the technical challenges and this is how we're dealing with the information about the technical challenges. The problem is that to find solutions to all those technical challenges at the same time hasn't proven so successful in many ways. And that's because I would argue we haven't had such a focus on the adaptive challenges. And that's things like the delivery mechanisms and the vaccine confusion and the vaccine hesitancy, how to reach priority groups, and how to respond to outbreaks that happen in the middle of your rollout plan. And I've found this a really useful way to think about, you need both, clearly. You need technical responses, but you can't solve these big, complex issues unless you also take into account the adaptive responses that are required. And as I said before, and I'll touch on this more, they require different ways of approaching the problems. You can't solve them in the same way. And so if we think a bit about what does that lend itself to then? I think it really means that we require ways of working and leading, and from our perspective, that's in a research setting, that really respond to these adaptive challenges. And that's what I would call health transformation. And I wrote an opinion piece a few months ago when we were in the middle of the sort of confusion around vaccines, and just talking about this was really highlighting how you might respond to an adaptive challenge. So I've just pulled one characteristic out here, and I'll talk about more characteristics in a moment. But just to read this paragraph, imagine if we invited aged care workers to design a vaccine rollout plan to reach them quickly and efficiently. Or if we asked those businesses currently experiencing QR code complacency to design a system that would enable maximum reach and use by customers. And what if we engaged a wide range of community groups to design vaccination messages tailored to their contexts and communities? So what this calls out, it's not trying to simplify the issue, but what this really calls out is that point that I spoke to under adaptive responses, that if you have an adaptive challenge, you actually really need to engage the users across the system to design the solution. And so overall, if we think about some of the theory on developing an adaptive response, these are some of the core elements that Heifetz articulates. So the first is to recognise it, to accept that adaptation may be needed, that it's not a simple, as I said, A to B solution, that you need to think about what do you keep and what do you change? And you might need to change that multiple times. And that's, you know, that's not our comfort zone. That's not the way we like to work. So there's a level of acceptance that has to be taken by all those involved. Part of that is this idea, he talks about getting up on the balcony. And I really like that, this idea that although it feels urgent and pressing, that actually you need to be able to take a step back and see the bigger picture, anticipate what might come next, because otherwise we do get the tunnel vision that means we just look at the technical problems and the technical solutions. As I've said a few times, there's a really important piece of work around building collective understanding and support for action. And obviously that includes getting the learnings from those who are using the system. And then this idea of being able to conduct rapid experiments, gathering feedback and using it to adjust and adapt. And I think, as I said before, I imagine that's an area that really resonates with your centre as it does with ours. And I think that's what's quite exciting at the moment, is that these new ways of working actually lend themselves to impactful solutions to what are some of the current largest health challenges. This is sort of the same elements put in my speak. This is how I think about it in terms of how we make strategic decision making in health a bit more agile. So again, that idea of taking a breath, taking a bird's eye view, I think that's something that collectively in research and in health and in government, we don't do enough, and it's priceless. Bringing people together with vision and strategy and then asking them to articulate the elements of the plan, again, is not done enough and is not done well enough. And I think there's a lot of research work that can go into how to do these things better. Exploring safe to fail rapid trials, and I'm going to talk more about that in a moment. And I really like this phrase, stay curious and seek feedback. And I think that idea of not having to have all the solutions immediately, again, is not our comfort zone, particularly not as experts or as government or as, you know, health professionals. And again, I think that's a learning we need to really explore if we're going to be able to have an impact on these health challenges. So I want to move now to how we sort of approach this as a research institute. So the Institute for Health Transformation was set up, I think, about 3 years ago, bringing together a range of different researchers from across Deakin and their partners. And we thought a lot about sort of our vision and our purpose. So we're not, you know, we're not a drug discovery type research institute. So our vision's very broad. It really picks up on the need for health and well-being, the issues around equity, and that's sort of what brings us all together, all the way from prevention to care. And our purpose is really about design and delivery. So this idea of partnership or collaborative research that transforms how we design and deliver prevention and care. So what we're really interested in is overall, you know, how do you make the systems work better for the people who need to use them? And that can be the health system, but we are also really interested in things like the food system or the systems of the workplace, and how you can organise those so that they really support and enhance health and wellbeing for everybody. Excuse me. We've got around 200 researchers across a range of disciplines, so public health and prevention, health systems and services, health economics and financing, and data and digital health, and really trying to bring the tools together that enable the way of working that we've just been talking about. And we really focus on, you know, what we consider to be some of the key complex health challenges. So I won't read all of these out, but you know, things like how do we get better integration of complex and fragmented service systems? How do we reduce persistent health inequalities, and how do we improve the sustainability of our health system? So obviously all complex VUCA adaptive challenges. Our research domain, so this is sort of the centres of research within a lot of our, within which a lot of our expertise is concentrated. So we have a domain focused on determinants of health. That includes things like, as I said, workplace, food systems, gambling, disability. We have a domain on obesity prevention, which also picks up a lot of the food system work, and then strong focus on systems approaches and community-based approaches. Quality and patient safety, which is primarily in health services, but also in aged care settings. and a large group in health economics, which is all the way from health economic evaluation through to health system financing prioritisation. And the way we work primarily is in partnership. So I've just put up, some of the different sorts of partners just to give you a sense that there's obviously, the obvious health sector partners, but there's also things like the construction sector, the Cancer Council, Ageing Research Collaboration. So depending on the challenge at hand, we have different partnerships. So for the last part of my talk, I really want to give a couple of case studies that talk to how we have been using the approaches I've spoken of and how we're trying to make them slightly more systematic. And I guess our key interest here, and I think we share it with your centre, is building the evidence to support this kind of adaptive health transformation. So at a high level, I guess what we're interested in is the concepts of, learning health systems. So how do we work with all these different systems to make sure that we are able to provide evidence that they can use to adapt and change and improve. And the improvements that we're interested in are not just patient outcomes, they're also healthcare workforce outcomes and sustainability outcomes, financial sustainability, but also environmental sustainability. The other part of this at a high level is, as I touched on at the beginning, how do you integrate research and development more into the health system? So I see these two high-level goals as very, very integrated with each other, but they're not always the same thing. There's a large body of literature on learning health systems and how we think about learning health systems, but I think less thought in that is given to how you actually integrate research into the health system itself. At the next level down, what we really focus on within the Institute, so obviously, we've got limited area of focus. These are kind of the key elements that we bring to the research projects that we do. So we have very strong focus on partnership and co-design, on systems thinking, on rapid trial methodologies, and on data collection that combines the routine data with bespoke data, and as I said, speaks to the different outcomes that we're interested in, and a strong focus on health economics and thinking about what is a sustainable outcome economically. So I want to give you a couple of case studies that illustrate this approach, and then I think we'll have lots of time for questions. So the first case study I want to talk about is in the population prevention end of our spectrum, and it's looking at community-based childhood obesity prevention. So this is a large program of work that is currently led by Steve Allender. And there are a number of grants and a number of partnerships, and I'm going to focus on one, which was a large NHMRC partnership grant which combined in Victoria Southwest, which combined partnerships with health services, PCP, local government and state government, and really focused on bringing together community leaders and consumer representatives to design a systems response to childhood obesity prevention. So they were sort of asked the question, if you wanted to improve child health and child obesity levels in our region with our particular issues, what is it that you would do? So that was that's kind of the really strong focus on the partnership and the co-design. We also had funding support from Western Alliance, which is a regional research connector type organisation, and Vic Health, which is the Victorian Health Promotion Foundation, which was really, really important, both because of the funding, obviously, but more particularly because of the perspectives that they brought from a broader set of stakeholders. And it was run as a cluster randomised trial over 4 years. So this is kind of one of the big challenges here, I think, is, how do you do research that's adaptive, that can be integrated into real time, into real practice, when our study designs are often over many years. And I'll offer some thoughts at the end, but it might be an interesting area for discussion. And so the way that one of the ways that we approach sort of this systems thinking, community or health sector based co-design is using these system maps. I don't expect you to read all of it, obviously, but we've developed a software called Sticky, which essentially allows groups to start to articulate together how they see the system in their area, in their context. So this one, as I said, was about the healthiness of children's habits as it pertains to obesity. So it was things like eating unhealthy food, drinking unhealthy drinks, making physical activity. And the different members of the co-design groups were asked to articulate, well, what did they see as the sort of biggest barriers or the potential solutions to improving the healthiness of children's habits in that region particularly. And what you can see here is that by using the software to do causal loop diagrams, you can start to paint a picture for that community of what their community system looks like. And here the different colours are different areas of interest, such as, so orange here is around physical activity. You can see the green is around food availability, etc., etc. And so then the community can have a look and see where they think the biggest issues are. So some of these loops that go round and round in a circle are really reinforcing, and the community can say, well, if we just broke that loop, that would have a big impact, and that might be where they choose to focus their intervention efforts. When they look at the map, they then identify their top priority intervention efforts based on evidence briefs that we give them. And part of that is that they have to be able to identify who would actually take control of that intervention. So it has to be something that's feasible in that context at that time. It can't be a what if or a maybe. There has to be somebody who could take responsibility for a particular intervention and oversee its development. So this has proven to be a really useful tool across the region, and they're now using it for a lot of other issues beyond childhood obesity. And within the trial, what it enabled was mapping of the interventions on these systems maps and tracking of what was actually done, which allowed us to do some process evaluations of the outcomes of the trial. So in terms of the trial itself, what we found was that over that 4-year period in the intervention communities compared to the control communities, there were positive intervention effects for the takeaway consumption by children and health-related quality of life. Interestingly, so we had an interim measurement and a final measurement. The interim measurement showed a significant decrease in obesity prevalence in children in the intervention communities, but by the end of the 4 years, that had come back together and there was no significant difference between the communities. So there's a lot of very interesting questions and work in terms of sustainability of these sorts of approaches when the research funding is slowly being withdrawn. How much can be embedded in the community itself? I guess in terms of this talk, though, the things that I think are really interesting to reflect on are the next steps from this piece of work. As I said, the community was very engaged with the process. They were engaged with having their own maps and being able to monitor the interventions that they chose to implement. So there have been a number of further trials with these partner communities that have really started to ask the next set of questions around, well, how do we ensure ongoing implementation? How can we capture adaptation and still have a kind of robust trial design? And how can we think about scalability without ongoing research funding? So how does this become something that can be picked up by local communities and local governments? And the other area that really emerged was, as I said, in terms of adaptation, not only do we need to be able to do it within a trial design, but there's a need for rapid adaptation. So things change a lot over the 2 to 4 year period of a trial. How does a community have the capacity to do that rapid adaptation and still evaluate the effects at a systems level? And so they're really important research questions. One of the things that same group has done in response to the question around rapid adaptation is work with some of our artificial intelligence experts to develop some what they've called rapid adaptive trial design based on Bayesian methodologies. And so what they did in this instance was they took one particular intervention, one particular outcome. So it was a focus with primary care on GP prescriptions for physical activity. So that was an area identified by the community as a gap. They didn't think, including the GPs, didn't think they were giving enough prescriptions or advice on physical activity. And so again, they went through a process of mapping how they saw the system and the different barriers and elements of the system that they felt were not supporting them to give physical activity advice when it was appropriate. And based on this, they identified 7 different interventions that they thought would be worth trying. So they were feasible interventions that could be delivered within a primary care practice and would potentially address some of the key issues identified in this sort of systemic diagram. And I'm not going to go into all the detail, but I'm happy to talk about it later if you like. But the interventions essentially spanned from putting a flyer at the counter when the patient came to check in, all the way through to the general practitioner having a script of what to say embedded into their medical manager desktop. So they had the 7 interventions from high intensity to low intensity, and they randomised them across the general practitioners and then kept swapping them week by week so that they could assess the binary outcome of, physical activity prescription given, yes or no. And what they were able to do, given that sort of Bayesian approach, what this graph demonstrates is essentially over a 12-week period, so as compared to a 3-year randomised controlled trial, over a 12-week period, you can see that the different lines here represent the different strategies that they were trialling. And quite quickly, you can see that the strategies here represented by the green and the brown lines started to separate from the pack. And so they continued this over a final few weeks to try and firm up the statistical power of the estimation of the difference. And indeed identified that actually quite low intensity interventions, so the pamphlet which was provided to the patient, but giving power to the patient, so the patient then brought it up with the general practitioner, and simply a sign in the waiting room prompting the patient to bring it up with the general practitioner, were actually the 2 most effective interventions. And so this has lots of really interesting implications in terms of the actual intervention itself, which I'm not going to go into. But what this method has enabled is within the broader community-based or health services-based systems work that we're doing, the capacity to say, well, this might be one way that we could more rapidly test specific interventions that come out of those bigger systems maps. And then we can work out which ones to keep plugging in and which ones to let drop away. So this has a lot of promise, which we're now trialling in other intervention settings. So I'm going to, again, pause for 2 seconds in case there's any immediate clarifications. Well, there's lots of time for questions at the end, but just any clarifications? Okie doke. So the final case study that I want to talk about is a different setting, so an acute care example. And this is one led by one of our joint chairs in nursing, Alison Hutchinson, who sits at Monash Health as well as Deakin University, and was a piece of work really focused on her content area of expertise, which is reducing preventable harm associated with neurocognitive disorders. It, again, was a partnership, so I'm trying to kind of obviously demonstrate the themes here around partnership and co-design, and funded by Dementia Collaborative Research Centre and the Commonwealth Government. So again, identifying a problem, as with the obesity case, identifying a problem that was of primary concern to the partners, and then working with them and consumers to identify solutions. Always informed, of course, by the prior evidence base. So the rationale for this piece of work was that patients who have behavioural and psychological symptoms from neurocognitive disorders, which the acronym is BPS, are at much higher risk of a number of outcomes. And this is a particularly high risk cohort in acute care. So if the behavioural and psychological symptoms are not recognised and well managed, then these things can be really disruptive in terms of acute care, can extend length of stay, and can obviously demand a lot of staff time. But what we know from the literature is that tailored interventions, so working with a patient to make sure that you are properly monitoring and assessing and responding to their symptoms as they worsen, can reduce BPS and these risks of harm. So there's good trial evidence demonstrating that the one-on-one type work is effective, but obviously that's not very scalable, and it's hard to manage large cohorts of patients across a large health service such as Monash Health or Alfred Health. Excuse me. So the goal of this particular piece of work was really focused on this partner need about how might we be able to use the research that we know to increase the uptake of these best practice guidelines by nurses caring for people with BPS in hospital in a way that might be scalable and still effective. And so they worked on a knowledge translation strategy to promote the use of best practice and evaluated the outcomes of this in terms of not the BPS outcomes. This was more of a pilot test type study, but the use of the guidelines themselves. So as I said, they used an integrated knowledge translation approach, which really engages obviously all the different stakeholders from the very beginning. And they were focused, as I said, on a process and outcome evaluation using 2 inpatient wards at one health services, Monash Health, and they had a different sort of set of patient mix and models of care. So trying to, not with any power, but just trying to make sure that it was actually usable across these variety of contexts. The co-design included consumer and the users of the tool, so nurses, and then implementation was across a whole ward at a time. So a really strong focus on co-design of the intervention and the evaluation, and thinking about how might the outcomes be integrated into usual care. And so what they came up with was an app they've called Braintrack, which really just builds on the current evidence. So it's not developing new evidence around how to manage symptoms, but it uses that evidence to inform the app to proactively identify and implement strategies at the point of care. So it pulls in the guideline assessment tools on the left to assess cognition regularly. It then immediately links to strategies that are evidence-based, given the risks that have been identified through the risk assessment. And then on the right, the graph hasn't come out, sorry about that, but essentially what on the right does is allow people to track over time. So this is something that's very hard for a nurse to do if they're coming in and out at irregular intervals, is to remember and recall, is this symptom slightly better, slightly worse? Was there a particular time of the day? So often with BPS, for example, somebody might start to have really strong reactions at 4 o'clock in the afternoon, or when they need a cup of tea. And so the time tracking is something that's very difficult to do without some kind of integrated application like this. And so this is the app that they tested. It wasn't connected to any of the sort of electronic health records, so it was a standalone app on a device. So as I said, this is not a controlled trial or anything similar. It was simply a usability process and outcome evaluation. And as I said, they looked at the evaluation of use of strategies by the nurses, so not the patient outcomes in this case. And what they found is for 2 of the strategies that are recommended, so engagement of family of care and carers and appropriate pain management, both of those improved during the use of the app. Through their process evaluation, they obviously got a lot of feedback in terms of which elements of the app were most usable, which were least usable, and what did the patients and the nurses experience through the use of the app. So from the app development perspective and evaluation perspective, they got a lot of positive feedback. So that team is now working to further develop app usability in response to that evaluation. This shouldn't be her, it should have to be EHR. But I guess the systemic question that I think it raises is, so they are currently planning a larger trial to evaluate outcomes, which does require thought about, well, how do we integrate this into usual care, into the electronic health record? And that's actually where a lot of the issues are arising. And I think this is a really good example because the sort of the technical challenge, if you like, has been dealt with really well. So how do we shift from what we know are evidence-based guidelines into perhaps usable practice on a ward? And so those results look really promising. But now to develop the larger trial evaluation, there's a lot of thought going into what I would call the more adaptive challenges. So the only kind of outcomes that we really want are to make sure that this is usable in usual care for all patients over time. So how do we make sure that we can do a trial that evaluates the broader context and system and allows us to adapt as we go and still has scientific robustness? So you'll see there's sort of a lot of common themes in what I'm talking about. So just to wrap up, so we've got lots of time for questions and conversation. I guess the main points that I would like to make are that I think the really big challenges that we're facing across the health sector, and again, I would sort of underscore that's all the way from prevention to care and end of life care and aged care and mental health, they're complex and adaptive challenges. And I think to deal with those, and from a research perspective, developing evidence-informed health transformation therefore requires these really quite evolved, I think, approaches to research. So that we need to think about what's a rapid, adaptive, integrated partnership research setup that can work for us and can still satisfy robust research outcome requirements. And part of that, which I haven't had a lot of chance to talk about today, is that we really need to ensure that we can have routine research quality data collection, because one of the problems with many of the studies that we're doing is we're having to spend so much time collecting data for one study that it's not very efficient. And so one of the things that they did in the obesity interventions was actually separately set up system-wide data collection in schools across the region that was supported by local governments, because they wanted to get information on children's height and weight. And so that's become a completely separate project, which has led to routine data collection of children's height and weight in schools. And I think we need to be thinking similarly for health services. How can we support health services to improve their routine data collection so that it is more research relevant and able to inform their capacity to adapt to all these complex challenges? So I'd just like to acknowledge all those involved in the work I've spoken about today, our partners and consumers and funders, and yep, very happy to take any questions and have discussion. Thank you.
Excellent. Thank you, Anna, for that wonderful talk. I see we have a hand up, Brian Chapman.
That was very interesting. And what I wanted to kind of query you about is this idea of safe to fail rapid trials and progress and transformation. So one of the things that really impacted me early in my career is I had the opportunity to work with a second-generation liver transplant surgeon. And nowadays they can, do a liver transplant without losing a single unit of blood. But when they first started, they would lose so much blood in a surgery that they would put towels under the operating room door to keep it from flowing into the hallway. And they would, the surgeons would keep, count amongst themselves how much blood did a patient lose yet survived? What patient did you have? So that is very, and you're dealing with a population that's going to die in the order of months, right? When you're doing this, but that seems very kind of a different, safe to fail. I guess you have to define what you mean by safe and how much risk you're willing to tolerate in the transformation of something, because we just know from mathematics, you can't get to a global optimum without accepting error. So we can do lots of kind of small local improvements, but to get to those kind of global reorientations of a system, there has to be, mistakes have to be made, and the level of mistakes that you're willing to accept at some point is going to drive how much transformation can occur. So just kind of curious on your thoughts about that risk to transformation ratio.
Yeah, I think that's a really good question. I guess the first thing I'd say is, and that's why I like that distinction between technical and adaptive challenges. I think technical challenges, which the liver surgery might fall into, I do think that's a different risk framework. So there's a lot more knowns. There are certainly some unknowns, but there's a lot more knowns, I think, in that when you're trying to perhaps evolve clinical practice. I'm not sure, maybe it was transformational, but if it's more an evolution, then absolutely, I think, you've got ethics frameworks and you've got risk frameworks. But in the adaptive space, or in the kind of, how do we transform the whole hospital, or how do we think about, changing triaging or inpatients or remote emergency care? There, I think you're quite right. And I think it has to be an explicit conversation. I think that's why the idea of trying to think better about engaging with stakeholders is really important, because we need to understand what are the different perceived risks and what is the risk appetite of the different partners in this potential change. And I think that, as you say, you have to accept some level of risk, but that needs to be really clearly articulated and accepted, so that somebody's not suddenly surprised at the end. But also, I think that's the other reason we need better data, because you need to be able to monitor it quite rapidly then, because if it is going down a path that is not acceptable, then you need to be able to stop and pull back. So I completely agree with you. There isn't a single kind of risk level, but I do think that idea of articulating it across the stakeholder group, getting agreement, and then being able to monitor it more rapidly are ways to mitigate the sort of potential negative outcome.
And if I can ask one follow-up to that. So I'm responsible for teaching informatics and data science to the medical students in theory. And so your early slide is stay curious and seek feedback. How much would you couple that with kind of the concept of skepticism? So, and science would be driven by a skepticism that we're not really doing it right. Right. And, you know, kind of one of my patron saints is Larry Weed, who would say all of medicine is wrong. You know, we're just doing it all wrong. We're training wrong. We're organizing wrong. And that kind of goes to you can't just go to the experts. You know, the experts are in the system and, you know, have created and been nurtured by the system. So what would be the message that you would pass on to medical students at the very beginning to inculcate this idea of curiosity or skepticism about what they're doing that requires continuous research about their practice?
Yeah, it's another really good question. I mean, look, I'm a very glass half full person. So I guess I wouldn't say, my perspective would not be we're doing everything wrong. My perspective would be, you know, we're being faced with really large challenges that are partly in response to how we've constructed the system, probably, you know, for good reasons, right? But now we need to do some adaptation, or we're not going to be able to maintain the high level of care that we, you know, we health outcomes care and in a financially sustainable way that we expect. So I see it more as now is a good time to be addressing these challenges. And I think that's the message. I mean, when I talk to students, I'm always saying, you know, you guys are the clever young things of the future. You're the ones that are going to have to think of new solutions. I think the stuff that I've been talking about today is really to sort of put frameworks around that. So you can't just have an idea and launch it and, you know, no care to risk or other stakeholders. But definitely, I think I would be encouraging people to say there will always be challenges. That's the nature of these complex areas. And so your job as a clever young thing embedded in the system is to be on the lookout for how things might be done better all the time. And then you have to think about how to do it. But I think that's a completely positive kind of approach to that issue.
Thanks.
Excellent. So Alison had a comment that leads right into that. Would you like to ask that, Alison?
I think you're on mute.
You're on mute. Yep.
Thank you. I just wonder what the impact is as medicine and healthcare has improved dramatically over the last couple of generations. Are the expectations of the public so high now that their risk tolerance has reduced to an extent that it's impacting on research and how you go about it?
That's a good question. I actually don't know the answer to that. I mean, sort of in terms of what I was saying before, my read of the situation is it's more that we are in a position now where we understand systems much better perhaps than we used to. Like that's a fairly new scientific field. And we recognise, I think, that some of the challenges that we're being faced with in health really lend themselves to being addressed as complex systems problems. So I think there's a bit of just recognition of them in a new way rather than increased, or decreased kind of capacity for risk. But I haven't really thought about it, so I think it's a good question and I will think about it more. The other thing I guess I would say is, and then I'll go back to that integration of research issue, R&D, that does appear to be something that has changed over time, that the research world and the health world have separated out more than they used to. So you used to have a lot more clinician researchers driving, and there's obviously health services, there's lots of other things, public health research. So I think that is quite an interesting question as to why that separation has occurred. And I hadn't seen it through the lens of risk, but I'll think about it more. I'd seen it more through the lens of everybody being driven to specialise and be experts in things, and so academia has become academia, and health has become health. And I think that's one job, is to bring them a bit more back together.
Thanks.
That was the question I was going to ask, is, what did it used to look like? It looks very different here than it did in the US, where I came from. And in some ways, it's more integrated. Well, one thing when I met with the head of pediatrics at Royal Children's Hospital and said, what can we do here that we can't do other places? And he said, there are more clinicians interested in research than there might be, back in your home. And so you can really get a lot of people involved. And I have found that to be true, that there's a lot more interest, but there's less formal opportunity for them to be paid to do research.
Yeah, no, I think that's right. And there's a really good report that came out of the NHS maybe last year or the year before, like just discussing this problem. So it's not unique to Australia. And I do think, you're right. And that's why I think, some of the conversations around, say, learning health systems, or, the work that, we've been thinking about in terms of how you do partnership research, I think there's a lot of innovation to be had there, actually, to really think about how do you make sure that research is still able to be internationally kind of relevant and applicable, but also can address local problems. There are issues in there that I don't think we've addressed very well.
Graham has his hand up.
Thank you very much, Anna. I'll just turn that. I'm a clinician out at the Austin, and I think that there is a huge clinician interest both in medicine, allied health, and increasingly in nursing for research. But I think Wendy's correct in the sense that the opportunities for carrying that through are not really built into our employment structures as well as they ought to be. If you look at the success rates on MRFF and NHMRC funding rounds, it takes months and months to get these things together. They're all consuming because they're usually put out with a very short lead time. And then the success rates is like 1 in 25 or 1 in 30 or something ridiculous that just is so demoralizing for people. So there's a huge amount of research done under the auspice of clinical audit. So low risk, data-driven and quality improvement type activities, some of which gets published, but a lot of which doesn't. So I think that, being able to frame that up and conceptualize it in a different way is probably really important. And the learning health systems probably do try to formalize some of that activity and bring it together a bit more. I was also just going to ask you about the concept of okay to fail. It's not something necessarily that politicians endorse as a public outcome. And I just wonder, particularly in some of the clinical stakes, we have lots and lots of clinical trials that never prove statistical success and they just fade away. But in terms of, if you actually look at how organizational restructuring happens, it's never put into a clinical trials or a social systems trials framework. They just sort of work or they don't. And so I just wondered, how we actually formalize that concept of okay to fail research, but put the outcomes into a constructive framework.
Yeah, no, I agree on both counts. So just going back to the, how can we structure the system to get more what I'm calling integrated R&D in health? So I agree with what both you and Wendy have said. And I actually think now is quite an opportune time to be thinking about this. So I know the state government is really looking at the health and medical research workforce. And I think people are realising, for example, from an academic perspective, that there's just not enough money in the system for people to be funded full-time on a fellowship for the rest of their life, for example. So I think people at the government level, at least, are starting to think about, okay, we need to think about career trajectories in health and medical research, and what might that look like? And I think there's a lot of interest in more formally recognising, as you say, not just medical clinicians, but allied health, nursing. So how can we think about recognising that research component in a way that makes the research system more sustainable? But I think there's also, and that's sort of, I've put it in there as sort of R&D, because that's something I'm currently thinking about. I mean, I think there is a lot of traction potentially in starting to frame up what that might look like for different organisations. So, you know, for example, you know, a kind of big metropolitan hospital has different opportunities and capacities to a small regional or rural hospital in terms of funding, research time, and being able to partner with academics. So I'm really interested in some of the you know, thinking that Wendy and I have been doing with another group. I'm really interested in what that might look like and different models for that. But as I said, I think there may well be opportunity to try and test those. In terms of safe to fail, yeah, I think, so I put that in because it's a term that I think is sometimes useful to think about, and it's used in some of the literature. It's probably not the one term you'd pick to advocate for this strategy. You'd probably talk about rapid adaptive trials. But having said that, like Safer Care Victoria, so they fund implementation work. They don't call it research, but it's very much framed in a safe to fail way. They don't use those words either, but it very much is about, we need to be testing things and seeing if they work so that we can continue the ones that work and not do the ones that don't work. So I think there is a recognition that we need to be trying new things and evaluating to the best of our capacity whether they're worth continuing with. So I take your point, but I do think that the practice of it is actually potentially recognised.
Yeah. Anna Griffiths has a comment. Would you introduce yourself and make your comment, Anna?
Thank you. So I've come in probably a bit of left field. I'm an information management background. I'm actually a librarian of a regional health service. I've started to take over the research office, and with an information management background, my first question to our IT and sort of systems were, what are the data matrices so we can facilitate better student projects and these kind of clinical audits and, you know, quality projects? And the answer was, we have no data matrices. We're working on a half paper, half electronic system. We have so little integration. We're on the border, so we have 2 state government requirements as well, which adds another layer of complexity. But really what I'm seeing is that the sort of lack of data or information access that we have through the health services is hampering research opportunities and this sort of quality work as well. Like you mentioned, the Safer Care Victoria Quality Coordinator, they're sort of unable to do a lot of the role or research that they would do in other health services because of this basic lack of infrastructure. So I've come into it thinking, surely there is a better sort of broader approach to this. You know, imagine if all Victorian health services had the same electronic medical records that were integrated. Imagine if we had a data matrices set that could be mined in this sort of big data way. My background in information management, this is the stuff we're talking about, you know, at least a decade ago. And I'm, I suppose, coming to health in a different way. My background was originally law library, so I've come across in, you know, sort of into health service going, okay, this is a new field. What's going on with research here? There's a lot of appetite with our junior clinicians. There's a lot of clinician researchers who want to get research projects off the ground. But I suppose I'd like to hear you speak to what you see with the future for this kind of big data mining, and, you know, how, I suppose, how we can facilitate improved systems that are interoperable, transferable, and possibly could be integrated, possibly at a state level, that will facilitate better research and outcomes and ensure regional centres like ours aren't left behind.
Yeah, well, hopefully I'm not going to be too flippant if I say I'm hoping that's what your centre is going to solve. Look, I mean, you're completely right, and I don't have the answer. There is no answer right now. I think, though, that we do need to increase the focus on those extraordinarily basic gaps. So we're also doing some work on sort of the healthcare workforce stress at the moment, and you know, one of the biggest things that keeps coming back to us is, oh, we can't even get the updated Word. So we can't even open, you know, like there's really basic IT infrastructure issues in our major hospitals as well as our regional hospitals. So yes, my nirvana is the same as yours, that we have this great interoperable, you know, integrated, standardized quality data set. But actually at this stage, I think we need to be advocating for, you know, and that's why I put that, that dementia, the delirium case up, because you know, this is the kind of thing that if we could roll it out into usual care, you're making an immediate difference, you know, across all patients. But we can't even integrate it with an electronic health record because the different health services have different systems, and, you know, how do you do it, and who's got the time to do it, and who's going to fund it. And this is one tiny project. So I really can't do anything except echo your amazement. But I guess the point for us is we actually need to be working out how do you solve that. And it's not going to be, you're not going to get the nirvana tomorrow. So what are the baby steps that we can take and advocate for?
Yeah. Thank you, Anna, for a very thought-provoking presentation, for the wonderful discussion. You'll see our next seminar will be in 2 weeks. It's Claire Craig of Sheffield Hallam University on making connections, co-creating a digital service innovation with people living with dementia. So, all right. Thanks, everybody. Have a wonderful day.